So, welcome to SAS 22. It's great to finally have a face-to-face meeting. My name's Adam Rehak. I'm an anaesthetist, but based on the critical care and paramedic heavy audience out here, that's probably something I could have kept to myself. What myself and my co-presenter here are going to do for the next hour and a bit is walk you through a journey which explores the challenging human factors in airway management. As a co-founder of the SAS, of the Safe Airway Society, I'm really excited to be involved with this event. The reason I say that is that the primary objective of this session, which is to shine a light on the complexities of interprofessional teams coming together to manage in often suboptimal conditions, time-critical situations, and deliver high-quality airway management, is an objective that meshes perfectly with the mission and the very founding principles of the Safe Airway Society. Before I walk you through what's involved with the session over the next hour, I think it's important that we define what we're talking about with with human factors in airway management. And broadly, what we're talking about is how you, as airway professionals, members of teams managing airways, interact with your environment. That can be how you interact with the people in your environment, or how you're impacted by the equipment, the protocols, the computer interfaces, the ergonomics, or even the culture within your organisation. What we're going to do over the next hour is use 4 videos that were produced for and shown at the World Airway Management meeting back in Amsterdam back in 2019 in the old calendar, or in the new calendar, year 1 BP, before pandemic. Seems like a lifetime ago now. At this point, what we're going to do is pause between each of these 4 videos, and the 4 videos depict a complex airway management scenario which takes place in the emergency department. Between each of the videos, we're going to pause and invite our panel of experts in airway management and human factors to comment on the actions and behaviours that are observable in each of these videos. We'll also ask them to comment on why situations like this evolve and take place in airway management, and what we can do to manage these situations optimally. At this point, I'd like to introduce my co-host, Gerri Khong, who's also an anaesthetist, but who you'll soon learn has an alter ego that moonlights as an emergency department team leader in her spare time. Gerri, would you like to tell us a little bit about our panel?
Yeah, so from the left, we have David Brewster. David is Deputy Director of Intensive Care and anaesthetist at Cabrini Hospital. He's a world-renowned researcher in airway medicine as well. He's also in the International Advisory Group to the Project for Universal Airway Management and the Difficult Airway Task Force for the Society of Critical Care Anaesthesiologists. Thanks, David. Next, we have Ben Meadley. Welcome, Meadley. Welcome, Ben. Ben is a paramedic and also got a PhD as a flight retrievalist as well. And then we have Brooke Dench. So Brooke she's got quite a CV. So she works for Boeing Australia. She's got a Masters of Human Factors and Ergonomics and is a trained psychologist. And before that, she was also an ICU nurse as well. And then farthest from me is Dr. Ian Summers. Ian is an ED physician and also director of Monash Simulation as well. Thanks very much.
All right, before we watch the first video, I just want to emphasise that, like any episode of critical airway management, you're going to see good and not so good behaviours here. I hope that we don't get too focused on the mistakes, errors, or areas where we think we can improve, that we can also pick up on some of the good behaviours that we see in these videos. I'll also emphasise that all of the people that you see within these videos are clinicians who are following a script. you'll probably rub shoulders with these people in your clinical lives somewhere along the line. And I don't want you to take any inferences from what happens in these videos as to their clinical competence. They are absolutely following a script. So with no further ado, I'd like to bring up the first video.
Okay, so I've got the bag mail mask, attach it to some oxygen. Oxygen's on 15 litres per minute. Check the reservoir bag is inflating. We've got suction. We've got a peak valve if we need it. And Marty, can you get me some blankets to ramp the patient, please?
Can we just assign some roles? Are we able to do that now?
Sure. So I'll do airway. Kelly, can you be the airway nurse?
Yep.
So are you happy to do cricroid?
Yes.
Terrific. Owen, are you happy to do drugs? Keep an eye on the monitors and be team leader while I'm intubating, please.
Yep, will do. There's yours.
Thank you.
What drugs do you want for induction?
So 100 mics of fentanyl, 100 milligrams of propofol, 100 milligrams of rocuronium.
Got it. 100 mics of fentanyl, 100 milligrams of propofol, 100 milligrams of rocuronium. No worries.
Great, perfect. Are there any other roles we've missed?
Emergency front and neck access. I guess that'll be me if it comes to it.
Yep.
And then Marty's our runner. Where's he?
He's just going to get some blankets to ramp the patient.
Okay.
Have anaesthetics been called?
Yep, they're away.
Okay, terrific, good.
Sorry, can we just go over the plan?
Sure. My plan A would just be direct laryngoscopy.
What size plane do you have?
Size 3 MAC blade. Plan B, video laryngoscopy. Plan C, LMA. Plan D, face mask ventilation. And Plan E, coupler neck.
I'll have to get Marty to get the video laryngoscope when he gets back. All right, Sarah.
So,
I'll come
what
back.
have you got? Have you got
Come
propofol
out.
drawn up?
Yeah.
Okay,
I'll
so
take
you
it.
just give 10.
Yep.
Just give 10.
All right,
Just
Sarah.
give 10.
That's
Just
okay.
give 10.
Okay, just slide that for me. Pop this on your face.
All right, that's 10 of propofol.
That's all right. You're right, Sarah.
You're okay.
You're okay.
Come on. Grip still.
Hang on, is she breathing? Is she breathing? I think she's unconscious.
Sarah?
So how much did you give?
You said give 10 of propofol. I gave 10 mils.
10 milligrams.
That's not what you said. You said give 10.
No,
I gave
10 milligrams.
mils.
Okay, so I said 10 milligrams.
emergency
Okay,
buzzer.
can we lie flat? Well, she's unconscious
emergency
now.
buzzer.
Okay, let's just change the oxygen over. Lie flat. How do we lie flat? Just lie flat. Does anyone know how to work
Down the end of the bed.
So we might just start. Ian, as an ED physician,
Yep.
I guess semi-urgent intubations are pretty much bread and butter to you. What are your thoughts about the planning and preparation in this scenario in your experience?
Yeah, thanks, Gerri. It's always interesting to start an intubation with the ominous background music. But it probably also is a reflection of just almost like the physiological response you get from watching something like that. So you can feel pulse rates going up, you can feel actually the stress. So the planning has to, in some ways, allow for that cognitive and emotional fog if it goes wrong. And I think in this case, there was a number of things that went reasonably okay. You know, it was a great video in that it wasn't sort of black and white, that this wasn't terrible. It had some aspects that obviously could have been improved. If you want to touch on some of those, in some ways we start to see the difference in communication between the different tribes involved in airway sometimes. And I think emergency and anaesthetics benefit enormously from cross-communication, cross-training. You know, one of the examples might be this sort of A to E structure that your emergency physician role was talking about. That doesn't sort of fit with the anaesthetics language and understandings of DAS guidelines, where that would be much more closely aligned to potentially a vortex approach of, you know, 3 or 4, with D being a front of neck access of some sort.
Okay. So I suppose with your ED experience and your human factors experience, how
Yep.
would you have seen this if we had to say this running well? What would you normally do?
To make it run well, do you mean?
Yeah.
I think in some ways that communication between airway assistant, airway operator, team leader, airway operator, airway assistant is much more of a dialogue than is what's shown there. So there's a cross-check that goes on. You know, the cross-check of expectations, the cross-check of expectations about drug dosages, even the cross-check about equipment. And one of the things that you know always strikes me and is a bit of a bee in my bonnet is this description about Plan B or whatever it was for them. That's video laryngoscopes, and that was it. That was the only definition. And sort of that's almost like the second ominous music stuff of knowing that there's going to be a communication breakdown between what equipment is expected by the operator and what equipment is going to be ready from the anaesthetic airway assistant. And probably the way that I like to teach and train and observe in those cross-tribal training is to have that as a communication conversation where you'd almost want the airway anaesthetic assistant to sort of cross-challenge or cross-check, what is it you mean by that? Do you want a hyperangulated blade? Do you want a Mac blade? What size do you want? Are you using a stylet? Do you want it preloaded? All of those sorts of conversation things should be a conversation of cross-check as well. And be able to withstand that fog. So when it starts to go wrong and you think, sitting in a tea room or sitting in this room and sort of intellectualizing that process, unless you're prepared for what it actually feels like when it goes wrong, then you probably don't have a plan that's going to be bulletproof.
Yeah.
And preferably train under those conditions as well, so the planning can withstand those challenges when you hit them.
So you touched on communication. I'm interested, Brooke. So with your human factors expertise and your experience as a critical care nurse, I suppose it'd be interesting to get your thoughts on the communication in that scenario, and how do you think good communication should look like in airway management and planning?
Yeah, absolutely. So looking at the communication we observed in this video, we saw good and bad aspects. So starting with the good aspects, we saw some closed loop communication. So our emergency trainee receiving the orders for the drugs for induction from the emergency physician, repeated back the information to confirm that he'd had appropriately, sorry, I've lost my words, heard the message and received it appropriately. We also saw, so in closed loop communication, you essentially are hearing the message and then you're repeating it back to make sure you've heard it correctly. And then if you're the giver of the information, you then have the opportunity to correct the information heard if it was incorrect. We also saw some ineffective communication. So we saw the order to give 10 of propofol, and that was misinterpreted to give 10 mils of propofol instead of 10 milligrams of propofol. So closed communication may have assisted in this instance, and I say may because there are a few other human factors scenarios that need consideration in closed loop communication. So if our nurse had heard 10 milligrams, repeated it back, she could have said, I'm giving 10 milligrams. She could have said, I'm giving 10 mils, and the emergency physician could have heard, I'm giving 10, and confirmed that as correct. And there's still that potential for error. So what I would see as a human factors specialist is looking at the design of our environment to see how we can avoid these types of errors. So how do we, instead of relying on the correct interpretation of communication, how do we design it so we get it right the first time? So do we need to look at guardrails that have one-touch, easy to use functionality that we get it right? So when we say give 10 of propofol, regardless of how it's actually communicated, 10 mils, 10 milligrams, we press 10 on our infusion pump and it gives the correct dose regardless. So trying to error-proof from a human factors perspective is not about trying to change the human, it's about trying to change the design. How do we change the design of our system to get it correct the first time? So regardless of what we hear. So overall, the best approach in my mind is to optimise the design, but then also bring in the closed loop communication so we've got both aspects to really avoid potential for error.
That's a really interesting perspective. You know, we focus so much on just training the team, whereas with your human factors and ergonomics background, you're changing the environment. I think that's really important to consider.
So I think we've got time for a question from the audience, if we have any questions from the audience about that first video. Did anyone see anything or confused about anything or like to comment on anything that they saw in that first part of the video? Looks like we've got a question up the front here. Have we got a mic?
Can you hear me?
All right, very good.
I've been a consultant anaesthetist for 40 years and I've seen a lot of drug errors, and I think particularly in the tense situation you cannot be too careful or check often enough, and I learned very bitterly managing a very severe anaphylaxis where we're running adrenaline at 40 mils an hour through a syringe pump, and when we swapped over from peripheral line to central line, the junior doctor reprogrammed the new syringe driver at 0.4 mils an hour instead of 40 mils an hour, and that put us back and almost killed this young patient. It was picked up, but I cannot emphasise how important it is to check and double check that exactly what you want to give is being given.
Thank you. Great points. Going to move on to the second video now.
So let's lie flat. Let's just get an airway. Okay, good. All right. So.
Do you want cricoid on?
Yep, whatever.
So do you want to put that on?
Can you? Okay. Well, I'm struggling to bag here. Kelly, just give me an oropharyngeal. Owen.
Yep.
Can you?
Up top?
Yep, up top.
Yep,
You can squeeze the bag.
I got it.
Alright, there you go.
Alright, we just need to get on and manage this airway now. Alright, okay. So just try. I can't get a seal. How are you going there? Alright, what is that?
Sats are still falling.
Alright, well, we're not oxygenating here. Alright, I think we should go to plan B. Grab a laryngoscope. Where's Marty with those black clips?
He had it, didn't he?
Let's have a look. Can't see anything.
What can I do?
Get anaesthetic down here urgently.
Okay, we'll do.
Alright, I need some burps, Sue. To the right.
Is that better?
No, to the right. No, my right. My right. My right.
Jerry, we haven't given any paralytic yet.
Okay, we'll give the 100 rock.
Yeah, fine.
Alright, so let's reposition the patient. Marty, where are those
Rock
blankets?
going in.
Okay, great. Look, I think we should reposition her whilst that's kicking in. So grab those blankets and the pillow.
Yeah, so
Alright, let's go. Okay, 1, 2, 3. Oh. That's good. That's just, no, that's too many. Alright, 1, 2, 3. Alright, okay, let's have another look.
Anaesthetics are on their way.
Great, Steph, can you grab me the CMAC, please? CMAC with the D blade.
Yeah,
Sure. Right, okay, let's have another look.
What else?
Bougie? I can't see anything. Just release your pressure. No, nothing.
CMAC's not available.
What? You're kidding. All right. Well, I'm just going to have to have a blind attempt. Just release your pressure a little bit.
Steph, have you looked in the where it's supposed to be next to the crash cart?
Yeah, I did. It's not there.
Right.
Did you know SAT's at 50%?
Oh God. Okay. So I can't intubate and I can't oxygenate.
So hold on, so we can't intubate and we can't bag mask ventilate.
Did you want an LMA?
Yep. Great idea. All right. Just any element.
How much air in the pump?
Any.
How much air did
No,
you want to
I don't know. Just pass me the element.
Okay, here you go.
Yep. Great. Thanks. Okay. Let's give some bags. This is still a big leak.
Well, there's still no CO2.
All right. Then we're going to need to go to the front of the neck.
Oh wait, I haven't connected the CO2.
Let's try again.
We've got, I'm told
CO2.
Yep, good, okay. All right, so the CO2 now, okay, all right. So let's see if the sats come up.
Coming up slowly. Coming up slowly. We're still only 83.
Right, well, yep, we're still not adequately oxygenated.
All right. I think we can all agree we'd rather not be in that situation. Ben, with your work as a flight paramedic, I'm sure you've got some strong ideas or feelings about team leadership. Would you like to comment on the team leadership during that scenario and how it may have impacted performance, and how we can go about optimising that?
Yeah, look, it's interesting. I think, actually, having watched the videos, I think they're doing a pretty good job in extenuating circumstances. Not only because Gerri's here, but because I think they're doing quite well, given the rapid increase in cognitive load. There's been little time for preparation, little time to get in the mindset of a critical environment. They've gone from kind of 0 to 100 very quickly. And even in my work in these flash teams where I won't have met anyone I'm working with often when performing similar types of procedures, you've still got a bit of time, but the time's been really compressed here. Needless to say, one of the things we've done in paramedic practice doing drug-facilitated intubation recently is to bring all of the senior operators to the head end, so that the two airway capable people are at the head end, whereas historically what we've done is split the two senior people, so one of the intensive care paramedics to the medications and one to the airway, and then what that often resulted in is people, when things started to get challenging, stepping over monitor cables to get to the airway end to help with the bougie or to help with some burp and all the rest of it. So we've reset now to have all of our expertise at the head end, with one of those people being the team leader and largely only being involved where they have to. The part of the cognitive reasoning behind that is that the airway assistant is as qualified as the person performing the procedure, whereas often we see in theatres that's not necessarily the case. We've got a airway tech, or you might have a nurse assisting you, depending on how it is, and they may not be credentialed in the procedure that you're actually performing. So we now have two people who are both credentialed in performing that procedure, so they both have a shared mental model from time zero, and they know what's going on. Now, we and everyone in this room are confident intubators, I suspect, by training. So we know that the chance of the person performing the procedure actually being successful is quite high. But if needed, the second expert is right next to them to just step in, but is also knowing how they're trying to troubleshoot. And then we've been more comfortable at delegating those other tasks, such as medication administration, checklist readout, and gear to the other paramedics at the scene. So whether or not that's appropriate necessarily in hospital, I don't know, but we found that has changed the way we manage airways and gives the person performing the intubation a bit more confidence that they've got somebody by their side, but at the same time, that person as the team leader can delegate tasks, has confidence that they are going to achieve we're going to be able to achieve the intubation most likely, but that they can step in. But I think in this particular instance, everyone kind of got sucked into the emergency. And then one person's performing cricoid pressure or burp that may not have originally been delegated that role. I'm not sure where the actual team leader disappeared somewhere at the end there. And then I think was coming around to help with double-handed bagging. But it was like a bit of a chessboard. Things were moving around. It'd be nice if everyone could start in the one position and finish the emergency in the same position.
It's interesting because it sounds like paramedics are coming from one end of the spectrum, which is the very opposite end of the spectrum to where anaesthesia is. You guys are very, from the start, like a lot of critical care areas, are very comfortable with having the airway operator and someone standing back being the team leader, whereas in anaesthesia, it's a change of dynamic to actually say we're going to have a hands-off team leader because we're largely a unit that doesn't have the capacity to have hands-off team leader. So it's about co-opting someone that comes through the door when you acknowledge a crisis. And I can see that you're trying to deal with an ergonomics issue by bringing both up to the head end, but I wonder whether you're heading towards a situational awareness problem by having 2 leaders in the one position. You know, and that'll be interesting to monitor to see whether that's an issue. Because clearly here there was not that distributed situational awareness by having the 2 people with their back to the monitor. And there's an ergonomic issue there that we haven't even talked about, monitors behind the head. But yeah, so it'd be interesting to see how that change in your sort of operating procedure.
It's interesting to see a large receiving trauma centre, for example, to watch, and something we've learned about a senior team leader hands off, because there often are the resources, and watch almost the conductor of the orchestra not have to actually do any procedure at all, and that is impressive to watch. Conversely.
David, I've got a question for you, and it's about 2 intersecting issues here, which is one around the, I think, misinterpretation or complexity of the term oxygenating and oxygenation, and the other is the use of end-tidal CO2 in all intubations, but particularly out-of-theatre intubations. We saw the team leader there say, we're not oxygenating, and clearly with no end-tidal CO2 on, that was based on a snapshot of what the SATs were at the moment, and subtly you could actually see that the SATs went up shortly after they decided to abandon face mask ventilation. So I guess my question for you is, what's your thoughts about trying to base your decision on whether you're oxygenating a patient on SATs alone? Should we be using end-tidal CO2 just as a monitor to say we're in the right place once we've intubated? Or is there a role of end-tidal CO2 during rescue attempts with face mask LMA?
The first thing I'd say is it's actually good that Nick Crimes is not here today with that question, or we would not finish. So, to get through it, there was a lot of good in that video, but yeah, it was very concerning to see someone look at the monitor and say we're not oxygenating. And I think I'm actually doing a study with Nick at the moment, which I'm not sure where we're up to with that. We're halfway through, I think, looking at the terminology of oxygenation, oxygenated, and the confusion that exists between emergency departments, ICUs, and theatre staff. Because clearly that patient was adequately oxygenated. No one's going to die with an oxygen saturation of 88 to 90%. And whether or not they're oxygenating or whether oxygen's being delivered to the alveolus is not represented by the number in front of you at that point, because that number represents what was occurring with your oxygenation and your ventilation 2 or 3 minutes ago. So what you really need is a marker of whether or not you're moving air in and out from the alveolus to the environment and back again. And that the best surrogate marker we have for that is our end-tidal CO2. So if it's not in the circuit, then you're really compromising your own ability to read the situation at that point in time. And really, you know, in theatre we're really good at having end-tidal in with our face mask and our laryngeal mask and with our circuit with our tube. But in ICU, what we often see is it's this thing that they want to put on at the end. And what I try and get through to my staff is it really needs to be in from the start as you're pre-oxygenating to know that you're pre-oxygenating adequately. And then if you do move between techniques of face mask ventilation or a supraglottic airway device, that you've got it in your circuit the whole time. And I think that's probably the most important role of end-tidal in those situations. The other thing, I mean, to harp on some of your points before, you know, they put in a size 3 laryngeal mask and they rescued, and then they got to a point of about a SAT of 83%. Again, that's going to be safe, but it may not be the best SAT they can get. And you could see that Gerri was already starting to think, I think the last comment at the end was, we're not oxygenating well enough or something, which was again an error. You know, at that point there, you know, an anaesthetist is on the way, and almost certainly a video laryngoscope will appear, and everyone just needs to stop, pause, because the patient's almost died, they haven't died, you've rescued it, now's the point to say, right, it's actually okay, we can stop now, we can do nothing. We don't need to instrument the airway multiple times. And what an anaesthetist might do when they walk in is a fresh set of eyes. Might be re-paralyse, might be wake up, we're not sure. Probably re-paralyse, reposition, get a better laryngoscope. But in the process of preparing to intubate, almost certainly would put in a larger LMA, maybe a second generation LMA, and try and pre-oxygenate better. Almost certainly the end-tidal is going to give you an idea of whether you are leaking around that as well. So there's lots of information the end-tidal can give you rather than just the tubes in the right place.
Fantastic.
Thanks. So we might throw to the audience now. Are there any questions from the audience with regards, for the panel, with regards to that section of the video?
Sorry. Ian, you mentioned earlier that there was talk of like the shared airway models, and you mentioned Vortex and DAS, and I think that we all see that they're very useful in certain situations, but in situations where the whole team doesn't share that mental model, do you have any strategies or ideas of how to best communicate, either using or not using those sort of approaches?
Yeah, great question. And we were discussing ahead of this session about the universality of across subspecialties and across also different cultural environments, how well understood something like DAS or Vortex would be. You know, my home is the home of the Vortex. It tends to be well understood across the different specialties, but still not universal. And I wouldn't expect to go to a locum somewhere and find that the Vortex would be understood. What might well be understood is the concepts behind it. So if you can translate that just into English and say, look, if I can recognise that I'm oxygenating, or if I am oxygenating and I'm not recognising it, can someone just tell me? You know, that's then still the Vortex, or it's still actually the understanding of what you want to get across. But now anybody that hasn't heard of that can understand that situation, hopefully, and be able to adopt it. Again, one of the things that we practiced at one of the departments I worked in is prior to a shift, the airway operator and the airway assistant go through a mental rehearsal model of actually physically going through an intubation. They do it with the devices that they would expect to use, and then just build into it a play. And that play is, okay, let's just assume you failed. Okay, well, this is what I'd do next. And so again, it doesn't depend on me talking about Vortex or DAS or anything else. Me and the airway assistant have been through those tasks ahead of times with the equipment that we're actually going to be using.
Thanks, Ian. I think Ian, you had a question.
I was just going to ask a question. We've touched on culture a few times. Just interested to hear from the panel. You know, what do you guys see as the enablers and barriers to departmental culture that can improve airway management, particularly kind of around tribalism that we've already talked on this morning?
We saw a lot of that with COVID. You know, we came up with a resource in guidelines and cognitive aids, and there was suddenly a need to disseminate that information really quickly. And what we saw across the country was really good behaviour between departments, really good collaboration between emergency departments and intensive cares and theatre, where we had people developing resources, and then those resources were shared very quickly, so we didn't all try and reproduce the same resource. And we saw interdepartmental simulation training that existed. And clearly that's the best way forward. Tribalism's not helpful in any way. I think we're all on that page. The enablers, I think, in some of the research we've done looking at leadership and followership, which we should have published towards the end of this year on airway management in ICU, looks at the enablers for good leadership and good team behaviours. And one of the things is having clear role allocation, checklists, which allow for a shared model for people to work off, as well as people who have excellent communication skills and leadership by example behaviours. So I think within hospitals, if you get those behaviours occurring, you then really just need champions from those departments to get along. So if you've got a local champion in ED who gets along with a local champion in ICU, you can have very good collaboration between the departments, and they can get on the same page, use the same resources, behave in the same way.
Yep.
Yeah, I'd echo that and touch upon what Ian said earlier, is early interprofessional training, getting the teams to work together. But as you touched upon there with the pandemic, the pilot principle came into play with the pandemic, didn't it? That if we didn't do the intubations right, we were going down with the plane. So everyone started to work together pretty effectively.
The fear factor.
Yes, exactly. Before I start the third part, I'll just point out that between the last video and this video, the confusion within the team between the CMAC and the actual desire for any video laryngoscope has been resolved, and the team has now managed to get their hand on the glide scope that was available.
There's still only 83.
Hi guys, Michael, anaesthetics, what can I do?
Oh, hi Michael, I'm Gerri. I'm one of the emergency physicians. Look, thanks for coming down. We've had a can't intubate, can't oxygenate situation with this patient that we were able to rescue the airway with an LMA. Look, the SATs are still pretty marginal. I think we need to get on and establish a definitive airway quickly, so I'm going to use a video laryngoscope.
Sure. Do you want me to have a go?
Yeah, that'd be great.
Alright, well I'll have a look with the video laryngoscope if that's okay.
Yep. What blade would you like?
Can I grab a Mac 3 blade?
Look, she was a grade 3B view on direct laryngoscopy. Wondering maybe if you want to use a hyperangulated blade?
Oh look, I'll just start with the Mac 3 blade and use the hyperangulated if that fails, if that's alright.
Okay, well you're the anaesthetist.
Well, I'm the anaesthetic reg.
Oh, I thought you were the consultant.
No, sorry.
Alright, so how far away is the boss?
Boss is just taking someone off table now. They're probably going to be here in about maybe 10 minutes.
Right, look, we don't have that long. Are you happy?
Yeah, look, she doesn't look difficult.
Well, I didn't think she looked difficult either, but here we are.
Sure. Yeah, fair enough. Oh, all right. Well, look, let's get set up. It's a bit quiet in here. Can I get the pulse ox SATs tone on?
Yeah, sure.
And the plan will be that we'll start with the Mag 3 blade, and if that fails, then the hyperangulated blade. And if all of that fails, then we'll come back to the LMA that we had at the beginning. Is everyone okay with that plan?
Yeah, sure.
Okay, great. All right, so you guys got bougies and stuff?
Yep.
Excellent. Okay. All right. I'll get that to you. Thanks. That's you as well. Okay. I haven't got a view. Let's try a little bit of burp. Up in here. No, still no view. Yeah, let's switch out for the hyperangulated blade. I'll come out here. Good. Thank you. Okay. That's better. Yep, so grade 1 view. Can I grab a bougie thing, please?
Yes.
Thanks. Okay. And then bougie through. Can't quite get that in. I'm just
You need to get the tip forward. Do you want a curved style edge?
No, this is okay. I've got a great view. I'm almost there.
No, you need something with a stable curve.
I just need a sec. I'm almost done.
Do you want some more laryngeal pressure?
Yeah, give me just a little bit more burp. Yeah, that'd be great. Thanks.
Kelly, do you have a curved style edge?
Just
Got this one here.
No, not that one. The one with the written curve. The one with the fixed curve. That.
This one?
Yep, load that onto a tube.
Okay.
Do you want me to have a go?
No, it's okay. I'm almost there. I'm almost there.
No. I
Won't be long. Just a sec. Got a great view.
really, look, I think I should have gone. Okay, so Ian, interested in talking a little bit about green zone opportunities. And so despite the fact that I earlier said that the patient wasn't adequately oxygenated, I think the team did recognise that at some stage there was some restoration of adequate alveolar oxygenation. And so I'm interested in your thoughts about what this green zone period affords us in terms of opportunities, and whether you thought the team did make the most of this opportunity.
So again, the skill of the video is the answer is partially. They partially recognised the opportunity, they partially created the opportunity. There was that discussion between you and the anaesthetic reg about what challenges you'd encountered, what view you'd encountered, the suggestion that maybe they had the opportunity to do something different. That sort of pace of conversation meant cognitively you'd recognised you were in a safer place, even if it didn't then go to the next step of actually let's go full inaction or inactivity, and we'll call it masterful inactivity because during that time you're doing everything to optimise, you're doing everything to get prepared. It's not just inaction, it's preparing for the next stage. What you then managed to do as a team is to take an area that was relatively under control and push it back out of control again. Whether this person was in the green zone, it's sort of hard because it's also slightly context dependent. The more she was something like an asthma and you're thinking ventilation is going to be a significant challenge, you think she's a head injury and actually the saturations might be, even worse. The trajectory was flat, so that single number is not so much the issue, and David's touched on this. It's that combination of this trajectory is stable, you've got end-tidal CO2 that's effective, you're in a pretty good space. And you know, next week when Adam's up Mount Kilimanjaro, his SATs are going to be 82% for the week, and he's going to be fine. She probably would have been fine, depending on what other pathology was going on there as well. But it's really hard in the middle of that flurry of action to actually stop and go, no, we're in a good spot. And we need to teach our trainees sometimes to recognise and celebrate, and that celebration of we're actually in an okay spot reduces the anxiety levels, means that we're not thinking from sort of brainstem level, but actually we can have the time to plan and discuss and go into action from there.
We talked a little bit about planning earlier, and in that situation, I thought the planning was probably incomplete.
Yep.
Interested in what your thoughts are and how that planning could have been better. There was a lot of bougies and stuff.
Yes.
And the plan seemed to end at an LMA. What are your thoughts about how that planning should look whilst we're in this green zone?
Again, that could be much more specific about what's coming next. You know, not sort of LMA from just give me anything you've got to, you know, LMA, this is what I want. And that's also going to be context dependent about what's going to be available. Ideally, the anaesthetic staff will know what's likely to be in the emergency trolley. And in fact, that should be standardised across the difficult airway in the theatres and the difficult airway trolley in the emergency department, so that equipment they're already familiar with. And again, that's part of the invitation that I give to the anaesthetic trainees at the start of their rotations, is come down to the ED, have a poke around our drawers, introduce yourself around, get to know the physical space you're in, what the setup is, meet as many of the emergency staff as you can. And in a small hospital, small rural hospital, that's absolute gold, because they're likely to be the same people. But recognising that in a big tertiary department, you're not going to meet the same people that you've met on that day, but at least you've got that feeling for when I'm called down in here, that I'm going to come into this room and it's going to look like this.
And certainly in theatre, we all know that, I know that the Kaika kit's on the back of the anaesthetic machine, but I'm not really sure where it is in ED, so that's such a good point.
Yeah.
So Dave, I'm interested in talking a little bit about the fixation of the team on the intubation, and I think we've probably all been in situations where our team's been fixated on a technical task. What are the factors, do you think, which led to this occurring? What are the things that you do as an intensivist in your practice and anaesthetist to mitigate these things occurring?
Yeah, it was interesting in that video, you know, once the anaesthetist turns up, they're very, you know, emergency staff are obviously very keen to hand over the airway, which is the traditional way of doing it, because here comes a more experienced airway operator. I think that communication was a significant issue from that person at the start, because they didn't get an introduction as to who they were, their level of experience, their level of expertise. And then once it was handed over, your good self stood behind them, which was a terrible place to team lead from, because you became engaged in only what the airway operator was doing or failing to do, and had no situational awareness of how the situation was evolving in terms of the saturation at that point. There was also a very rapid handover and removal of a safe device, when you really should have had a shared mental model understood by the whole team, which was, all right, we've got someone here now who could potentially intubate, we're going to try this, and at this point we're going to abandon. And we did that well with COVID, where we said we're going to try not to face mask ventilate for the safety of the staff, was what we thought initially, but if the SATs get to 88, 85, 80, whatever number, at that point we're going to face mask ventilate. So in this scenario, what should have happened, in my opinion, is that you should have, as the most experienced clinician, led the scenario and moved around to the other side of the bed, where you could see the monitor and you could dictate when things were to change, at which point you'd say, if the SAT's at 70%, we're going to stop attempting intubation and we're going to go back to an alternative ventilation strategy with a laryngeal mask, size 4, with end tidal in the circuit, and we're going to wait for your boss to appear for the second go at video laryngoscopy.
Okay. You've written a great paper, plug for your paper, or a review of leadership in ICU. What do you think, in a crisis like this, are the key dimensions of leadership that would facilitate it?
It's interesting because at this point, shared leadership or distributed leadership is really good in airway management in ICU, particularly around role allocation or reading a checklist. And you often find a senior nursing staff member might actually go through and help with a lot of that, or a senior registrar. Once you get to airway crisis, actually many team members feel more comfortable with a really clearly defined hierarchical system, where you have a very senior person who is seen to be cool under pressure, who seem to be a content expert, who seem to be very clear with their communication, who can calmly walk the staff through. So you have one clear voice, but all of the followers clearly closing the loop on what the communication is, and having a shared mental model where everyone actually understands what's happening, because you all understand what we should be doing, but that one voice is just verbalising it so that we're all on the same page and calming everyone down. Good guidelines like Andy's and the Difficult Airway Society's most recent guidelines actually have a lot of that embedded in them, about having a shared mental model and about how communication and human factors are embedded into the guidelines.
Brilliant, thank you.
Yeah.
All right, I think we've got time for audience questions. See any hands in the audience? Anyone like to ask a question? Matt?
I'll just yell out.
All right, go for it.
Just for the group, there was obviously a call for help, and someone with great skill set arrived. I wouldn't say it's with overconfidence or swagger, but it was a little bit dismissive to Gerri's concerns about anticipated difficulty that was encountered, progression based on what they thought was the best approach. And then when in the airway there was, despite Gerri's prompts to get out and to maybe change approaches, this continuation of that conversation on continuing intent. I was just wondering if maybe, Brooke, from your experience with Boeing, if there's any ways that this can be mitigated to check one's ego as they enter the room and make sure we're not dismissive of others, and also during those critical points where one patient hardware gives some pretty abrupt language that we need to pay attention to.
Yeah.
So, sorry, I'll just paraphrase. So for those that didn't hear, the questions around mitigating the risk around overconfidence or ego, or just not knowing what we don't know, which is often the case as junior registrars. Certainly part of the reason we wrote this video was because we had a litany of errors that related to sending our junior registrars to the places where the worst airway problems were occurring, patients crashing in ICU, patients unable to be intubated in ED, so we send the most junior person, and that's what you expect. So Matt's question is around any ways to mitigate that risk.
Yeah, absolutely there are. I have seen in other areas there's training around language where you can actually speak up. So it's an escalation process. So if you're seeing something that's going amiss and want to say something, you can approach it in a curious type way and say, can you explain why you're doing that? Or, and then there's an escalation process that goes up the chain. So if you get to a point where you're feeling really uncomfortable, everyone has agreed an agreed term. Whether or not it's a red flag or another agreed term that a particular organisation uses, where someone can say it, everyone stops and, okay, we need to reevaluate the situation. That's a really good way that I've seen effectively used in other areas, that people can actually stop, okay, let's take a moment, regroup, actually understand what's going on here, have a conversation.
Adam, if I may, a reflection of your comment also on you send down the junior anaesthetic person. Often I think the emergency departments are poor at telling you or engaging in that conversation of supervision of intubations. And I reflect on myself, the intubations I do now are primarily supervising other people and bailing them out of trouble. And I think that is such a high skill level to expect of, let's say, a junior anaesthetic registrar, that it's almost one of those ones where you go, actually, I'm not senior enough to supervise you doing it. I'm much more comfortable to do it. And in effect, when I think of that poor anaesthetic reg that turns up, he might have done, let's say, for the sake of the argument, 100 intubations. Probably 99% of them have been really easy. So it's fair to be confident in that mindset and be able to say, look, you might have struggled, but really you probably only do 5 a year, so I'm going to give it a go because I've done 100 of these and they were all great. I think probably, in a way, we all come from that viewpoint of actually good intentions, and we're sort of sucked into the swagger of these are actually pretty easy now. It's only then that you don't factor in, well, why is it a challenge, or not learn from the previous attempt and say, actually, I'm going to do something different. Either you've positioned badly and I'm going to change it, or I'm going to use a different device, and the hyperangulated is the obvious one to have perhaps used right from the start on that attempt.
So it's interesting. Certainly our organisation has recognised that we don't see an easy mitigation to the risk in how to either improve the way emergency can identify which the high risk ones are, or to provide our junior registrars with better insight as to know when to call. And we've created a standalone position, which is essentially the trauma anaesthetist that does nothing all day, but be available for emergencies in theatre, off the floor, ICU. That's their pure.
Yep.
So they're called the clinical assist and trauma, or cast anaesthetist, although it's translated to coffee and sweet treats because they walk around doing a lot of servicing other theatres. But it's been a huge benefit because they've now become the diplomats between the emergency department and the ICU. They spend a lot of time there and they're building bridges so that they're breaking down some of those silos, which was something we talked about in the last session.
Yep.
So.
Great.
All right. Last part of the video.
I think I should have go.
Have you got a flex tip bougie?
No,
I'm sorry, I don't know what that
I
is.
think we're out of time. Do you want to just move out of the way? Just hand me the discussion. All right, so we're going to put this away. So we're going to have one attempt with this. And if that doesn't work, we'll go with an LMA. Okay? I've got a good view, but I just can't get it in. Look, let's just go with the other mate. Thanks. Alright. It's back. Okay, so bagging reagent total CO2.
No, nothing convincing.
So, alright, look, I think we're going to have to cut the neck. Alright, Kelly, can you get me a crack kit?
The EMT reg is in the department seeing that epistaxis patient. Do you want me to get them?
Can you go get him or her? Right. Look, we're going to have to position her for a surgical airway. So, neck extended. Okay, pull me up the bed and pillows out. Pillows out. Pillows out. Right. Okay.
Jerry, I can't find a crack kit. I'm not sure which one you need.
There should be a standard inflagotic rescue kit in there.
No, I've got a cuffed emergency kit, I've got a retrograde intubation set.
No, there should be a standard e-phono kit that the hospital has. It should be in the drawer, like front of neck access. It should be in there, in all of.
I'm sorry, I don't know what you mean. I can't see it. I don't know what that is. I don't know.
Okay, so forget that. Just get me a size 10 scalpel.
Yes.
A bougie, size 6 tube.
I've got scalpel.
Just
One
have
more
a
neck
feel.
extension.
Yeah, just have a feel. Okay.
This is Kathy, the EMT reg.
This is a Kaiko situation. Can you do e-phono?
What? We can't make that situation here. We need to do an emergency surgical airway. Are you happy to do it?
Okay. Can I get some size 6 plus and some betadine?
Don't worry about that. Don't worry about that. Just put these on. This scalpel.
Okay.
Put the bougie in the tube.
Can I get some gauze?
Look, I don't think we have time for that. How about if I'll just take over? Thank you very much. Sorry. All right. So just pass me the bougie, please. All right. So pass the bougie, thank you. All right. Tube over the bougie, thank you.
I've got the bougie
Got the bougie, all right. We'll keep holding the bougie. Okay, bougie out. Bougie out. Bougie's out. Thank you very much. Okay. Up. Pops up. Right.
And tighter.
And tidal CO2's up.
It's about to come up.
Looking good. Saturations
Saturations
are
are coming up.
Nice work.
We got there in the end. There's just some credits for everyone that's involved. I'll let that run through because it was a major effort getting these videos made. So I think everyone involved should be acknowledged. All right. Got a question. There was the decision to perform some sort of a surgical airway was made reasonably quickly, but there was a bunch of problems that got in the way with the actual execution. I'm just wondering what you think contributed to the failure of execution and what you could do differently, or any lessons you've got from retrieval that help with getting execution right when you decide to do it.
Thanks, Adam. I think, many of the issues are quite evident. So there's the language around what device. There's a list of 10 different, whether it was phoner, e-phoner, crike, kyco, etc. So there was some confusing language. And I think one of the lessons that, because of working in an environment where you're always going to have limited resources, whether they be human resources or physical equipment, it's very easy to standardise because you can only fit so much in what you carry. So we're fortunate in that regard. And I think it's a great contribution that the society makes is this effort to standardise despite the barriers that are there. But the benefits, I guess, from my experience and linked to the issues we see here is if you can call it one thing and everyone agree on calling it the one thing, it doesn't matter what you call it, I don't particularly care. Call it crike, call it phoner, whatever it is. But it's called the one thing, and there's a mandate somehow that's what it's called. And then you've got your disparate departments coming in and going, we all know what we're talking about. And again, one of the hard things about working in a contemporary hospital environment is the exceptional level of workload means that the time to prepare for such events, it's almost a unicorn in that, we'll spend the morning just going through all of our resources and practicing. Now, certainly in paramedic practice, we have that opportunity more so. And I'll use a case example of relying on my air crewmen who are trained in a medical technical role, where we had a failed proprietary crike device, but we had drilled the scalpel finger bougie tens of times over, and I didn't have to ask a non-clinician what I needed to do next. It was in my hands. And that was, again, in our environment, the ability to standardise and practice with reasonable frequency. Everyone at that scene knew what the one device was. They all knew where it was, and they all knew how to use it, or at least what their role in that procedure was. So very difficult in large organisations and disparate populations to achieve the same, but I think it's a lofty but achievable goal, and the society contributes well in that regard.
And I think that argument about, it's just too difficult to do has been used as a soft excuse a lot of times. The difficult airway trolleys in most anaesthetic departments, not only are they confusing and a barrier to patient safety, but they're also an OH&S risk, because you open the drawer and this a mountain of equipment comes pouring out because everyone wants their little thing that they've used, and it's just a disaster.
I think it links to that leadership as well. It takes very strong leadership to cater to all of those desires across an organisation, to say, well, I like to do it this way and I like to do it this way. How does the strong leader in the contemporary era say, well, we're doing it this way? And that's the end. So that's challenging in its own right, but sometimes that strong leadership is ultimately serving the patient and the clinicians best.
Yeah. I've got another question for you, Brooke, about communication. You seem to have got all the communication questions, but I guess that's because no one's going to take a bloke talking about good communication seriously, so they're all coming your way. But we saw, not just there, that word salad of, kyco, phoner, infraglottic rescue, and earlier asking for a CMAC rather than a video laryngoscope, and that causing confusion, that this failure to have a shared vernacular was a real issue. What are your thoughts on how we can get around that or start to avoid these communication problems in airway management?
Yeah, absolutely. Well, first of all, I think my husband would completely disagree about me taking advice from me on communication. But definitely, from my perspective, again, let's not try and change the human. Interprofessional training is really important, but how do we change the system? So Ben touched on it nicely, having standardised language. Let's have a set of guidelines. What is the language we use for different things? You know, we're referring to CMAC, GEICO, ePhona. What exactly are we going to refer to as a profession? And then following that, having a standardised equipment and devices. So our product labelling. You know, how does product labelling, for instance, impact this? If we've got agreed terminology, let's label it really clearly on our packaging. We saw a lot of flipping back and forth, looking for different pieces of equipment. Is this it? That's a lot of wasted time that humans are better spent doing other things that humans do best. So how do we bring in technology to support this? You know, if we've got checklists available, can we make them digital? Can we use QR scans, barcodes if we're looking for particular pieces of equipment? How do we bring in technology to enhance human performance? And finally, once we've got a standardised approach, we've got standardised trolleys, we've got technology that actually benefits and adds value, that's when we bring it out into professional training. We have a shared critical language where we can know exactly where we're up to. It doesn't matter where you're from, which department you're from. We know exactly where we're going next. So having that shared mental model, that distributed situation awareness, so then we can perform what we as humans do best without mucking around trying to work out what the language is, what piece of equipment we have. That's all standardised. We have technology that can actually assist with that.
One of the arguments for putting our emergency surgical airway equipment up in a visible location is not just so you can find it in an emergency, but so that they're serving as a heuristic reminder that these situations occur. In critical care, you probably don't need these reminders because the figures are stark. You're dealing with a population where you probably need to have it in your mind fairly frequently, but in anaesthesia, where you're dealing with a whole different cohort of patients, where you'll see emergency surgical airways so infrequently, having a reminder there to get you past those biases and sort of mental roadblocks that this is actually happening can be quite valuable. Is that part of the work you do in human factors, thinking about the heuristic value of things, and any examples of how you design things, other things that help in that way?
Yeah, absolutely. So I guess there's a whole range of different ways you can design things to promote the human performance aspects. So we could use eye tracking technology to understand how people actually scan airway trolleys, for instance, when they're looking for pieces of equipment. We could look at cognitive workload as well, how we actually minimise that to create space to allow their decision making and the pre-planning that comes with that situation awareness as well. So there's a range of things that we can do, looking at design in particular, where we can free up those cognitive aspects, look at how humans actually perform in a clinical scenario, and then lay things out in accordance with how we actually behave.
One of the great examples, of course, is cannulae, if that's what we want to call them, because everyone identifies them by their colour. It's been a great success, I would have thought. And I doubt many people read the label.
No, that's exactly right. Yeah.
Good point. I'm interested, both Ian and David, do you both work in organisations where the emergency airway trolleys have been standardised across departments?
Yep. Yes.
Yep. Okay. Show of hands, anyone here work in organisations where you'll find exactly the same layout in your ED, ICU and potentially operating theatres as well? Very good. Okay. Gerri.
Interesting. Any audience questions? Last opportunity.
Start of the talk, you talked about the kind of cognitive fog that we can all experience clouding some of our decision making during a crisis like this.
Yeah.
I'm really curious about what strategies the panel has to kind of cut through that fog.
Do you want me to take this first?
No.
Ben, do you want to go this? Actually,
I can.
Have a listen in and then add if you might.
Go.
Because you'll need to. This is really tough stuff. And there'll be people in this room that know exactly what it's like, including myself. When you hit an airway, not only it's difficult, but you've created it. So you have that second layer of, oh my God, I've just on top of everything else. I think probably one of the things that we need to think about is not an individual, but a team responsibility for helping each other out of that situation. And that may just be as simple as a trigger or a reassurance or a reprioritization back to, Ian, remember you can use your bag veil mask. You know, something as simple as that might be the reset of, oh yeah, it's not yet a disaster, let's go back in. And we underestimate just how significant those prompts that come from empowered followers can be towards a team leader that's really struggling at the time. It doesn't often need much to just reboot into a much more meaningful way.
Yeah, I think it's one of the key roles of the followers in these scenarios is to support the leader when they do get fixated or they do freeze. So you saw there, I think once the registrar said, well, actually you couldn't face mask ventilate, but would you like a laryngeal mask? I think it was in the second video. And also someone else has walked in the room and said, well, there's an ENT person, would you like them? Or they've said, should, you know, the SATs are low. Did you know the SATs were 60 or 50 or whatever in the first or second video? So that's a really key role of all followers in our airway teams is to help the leader when they actually hit a roadblock and they're actually going down the wrong path.
Yeah. Ben and Brooke, have we set you up?
Well, I can think of a case example recently of flying an hour and a half north somewhere to a very, very, very small hospital, urgent care centre, and to back up two very experienced senior paramedics who were having some trouble. But they had got things sorted in the interim, and I unfortunately timed the walk in the door as, you know, hierarchically the senior clinician with the scope in the mouth. And a couple of there'd been a failed intubation previously, and they were having the second attempt, and some of the other highly cognitively charged staff at this small hospital were screaming about the saturations and the heart rate, and so for then I had to quickly appraise the situation and say, what do I need to do anything? The paramedic's got the scope in the mouth, that looks like it's okay. The numbers that are being screamed are actually okay. And all I need to do is go on to say to the paramedic, proceed, the SATs are okay, everyone's okay, do what you're doing. And it was successful. And it was just sometimes, like you say, just taking the heat out of the moment, reassuring everyone that they're doing what they're doing and that everything's going to be okay, was enough to see the trajectory of that, you know, probably what might have gone one way, go the way we hoped.
And it's interesting, so when I was a nurse, I never knew what information was needed to the airway clinician at the time. So, you know, me shouting SATs are, you know, 56 or whatever, is that useful? I had no idea, but it was almost like it'd become the culture and the thing to do. You just yell the SATs out at particular points in time. When do we actually, what information do we need at particular times to make that helpful, or does it just become white noise? So,
the relationship between Gerri and the airway nurse is an interesting one to look at as well, because it goes on it's got a very negative interaction very early on, and they don't seem to recover throughout the videos. And I think that impacts also their performance.
It's interesting to see the labouring, briefly, the labouring of the error, the labouring the point. I would say to my kids, we can't change the outcome here, we need to move past it. And you know, you try and do it pretty quickly, and it's hard, but you can't change the outcome, can you? So.
I don't know whether there's validity to it, but within a debrief of a very, very stressful airway event, we often talk about this. So we normalise the human reaction and say, actually, this is going to be part and parcel of what you're experiencing. So that's why we're challenging you in the simulation space, to prepare you for that feeling of when it's going to come. Then it's like, oh, there's my old friend back again, that feeling of dread. I've just done something. Here's the reboot strategy you used then, or here's what you could have used, and we might have practiced it. Normalising that makes it human behaviour rather than me as an individual. I think that's got benefit. Even discussing in this room has probably got benefit.
So, question about simming or training for this scenario. I guess we talked about the barriers to performance in terms of the surgical airway there, and we talked about some of the enablers about standardising things. Do you think there's a role for standardising the point at which we start to prepare for surgical airway? Because I would argue that that preparation occurred far too late there, that even if we hadn't seen some observable concrete triggers during the scenario itself to escalate the level of preparedness to perform a surgical airway, the moment that they restored oxygenation and then came up with a new plan, I would have thought that at the very least they should have had the kit out and someone allocated ready to do that. What do you guys think, and what would you use if you were simming this? At what point would you be hoping that in rehearsal that the kit would be out and ready?
When you see really, really slick teams doing this, and often they've been through drills and they're primed for deterioration. So it's slightly artificial. Obviously, you're turning up to how to handle the challenging airway course. You know there's going to be challenging airways. When you see it done really well, there's attempt, there's planning for attempt, there's preparation by team members for the next one. And so the prompts and the triggers are getting factored in and built, and teams will fly from one to the other. And then almost like the challenge becomes actually when to stop the progression so that it doesn't go down this runaway train down to an inevitable end, which is why we talked about that the joy of celebrating the success of the green zone is actually, no, we don't need to go. So it's primed, trigger, onwards through a smooth flow with equipment ready, but able to be stopped at any time when they recognise they've got a success. And that's the way it works.
So is that in real life, Ian, or is that in...
I've seen it both. I've been part of it in both. It's observing in sim teams, but I've also been part of watching that process and being part of really challenging airways where, in fact, that's what's happened. And it's a real joy to be part of or to observe in either setting.
It's an odd video, that one, because given they could get the view with a high-angle blade, given the most expert was a possible junior anaesthetic registrar, you would argue that they should never have had... The end result should have been the patient was successfully intubated. They just made a whole bunch of poor decisions along the way that they had to rescue it. And it's obviously a lot nicer to rescue with a surgical airway when the SATs are 90 than 40. But if they'd made a more sensible decision back at video 2 and put in a laryngeal mask that could oxygenate the patient back up to 100% and waited for an expert to arrive who could have intubated the patient or intubated with a scope down a second generation laryngeal mask, we never would have got to hypoxia again, and we never would have got to a surgical airway. So it is, there's so many outcomes that are possible depending on how you behave as human beings, what decisions you make.
Sorry, Dave. I think one of Ian's points about, in the simulated environment, you have the pit crew almost ready to go. In this particular situation, the situation was forced very quickly. It wasn't it was a planned intubation that became an emergency airway very quickly. So having that drill ready to go is I guess where all of that cognitive load is overwhelming, and then can you actually get the team back into each position they need to be in? And I think we're lucky in the way we do it because we use it via a checklist, and it's not, we know where the correct kit is, it's out, it's ready, even to the point of, David may talk about later, for anticipated difficult airway, the double setup of the person there effectively with scalpel in hand ready to go as the end point. So the end point's predetermined, hopefully we never get there, and everyone is on the same page from time zero.
It reminds me of, I think 2007, when Nick Crimes came to me with the Vortex and said, what do you think of this? And I said, it'll never work, it's too simple. It's too simple, it'll never work. And that's exactly, it's one of the few mental models that you can impose in that situation where everything's run off the rails, and trying to remember some complex multi-armed airway algorithm, particularly when it's linear and you've come in from a different pathway than through the intubation pathway. Having something that is simple and works no matter which pathway you've come into that has been a bit of a revelation for someone teaching this stuff. So. We've probably got time for one more question if anyone's got a question in the audience.
Hello. My question is about planning, and I would appreciate a multidisciplinary response if we have enough time. From this video, it was quite clear that often at the planning stage, we focus on the procedural side of things, plan A, B, C, D, etc. But we're often quite blind to the real complexity of an airway crisis that might be evolving in front of us. How do we have ways to actually ensure that teams actually deal with the full complexity rather than just the procedural side of things?
So, would it be fair enough to say, how do we, so from that we know that failure to plan for failure was an issue? Is that kind of what you mean? So how do we avoid failure to plan for failure?
I think from watching this, it seemed to me that there were more than just the airway management aspects that actually failed them. There were team aspects, equipment aspects, whether people were ready to actually execute plans that had been forecasted. So yeah, how do we deal with that in a practical sense? Because we don't have 2 hours to plan for an airway crisis, but at the same time, it needs to be planned.
I think what you mentioned earlier about common language, common equipment, a common shared mental model, which takes, it's about getting all disciplines in Australia and New Zealand to that page, which takes time. So it's about embedding it in the training of anaesthetics and ICU and emergency medicine and critical care nursing and paramedicine. It's about having shared language and commonly accepted, this is one way to do it, and this is the way we will do it, and this is the equipment we will use. These are the cognitive aids we will use. You know, this is the terminology we'll use, and this is the accepted approach. And having that, you can't have universal practice of everything, but as much as possible, that's one way to do it, because then when people walk in, they have an expectation that is the same as the person next to them, because that's how they've been trained, and that's what's endorsed by their college or their society or their learning organisation. So I think that's one specific way, and I'll talk later about algorithms and guidelines and the overabundance of these things. We have too many, and there's confusion that comes because people don't know which one they're working off, where we really only often need one, you know, for that context.
So shared mental model, essentially.
Shared language as well, yeah.
And having that agreed approach as well, it frees up the cognitive aspects then. So you're not having to talk about insignificant things that actually don't contribute to the scenario. Instead of having to problem solve, terminology and equipment, you're actually able to problem solve the scenario and use that cognitive workspace that you've created by removing all this poor design to actually start problem solving and planning and communicating more effectively.
Yeah, I think what you don't want to hear in an airway crisis is in our department we do this, or in my hospital we do this. When I was at the X hospital we did this. At North Shore we do this. One is just the way to do it.
Absolutely, yeah. I think every self-help book says plan for success, but planning for a failure from time zero here says that most of the time, and you speak to the different craft groups where in anaesthetics and emergency airway crisis, by proportion of the total airway experience is very small, and it may be different in other craft groups, but if you're always planning for failure, then you're probably going to succeed most of the time, but you know that there's a solution to your problem. And again, that's the household thing, there's a solution to every problem.
And we all do ALS the same. So, the ARC puts out guidelines which no one tries to replicate, and if the patient arrests, we all do ALS the same. So an airway crisis shouldn't really be different to that. It should all be done the same.
We do CPR differently.
Do you? You do it better. You do it a lot better than us.
I think some of this is also a little bit about self-awareness. So you'll all have coping strategies that you use under stress, and some of you are better at it than others. And so sharing those and talking about those and preparing those will cross between this emergency situation and this one, because you'll use some of the same strategies. And that might be ways to control your breathing, ways to control your voice, ways to project yourself under a crisis. It may even be ways to prepare for a procedure that you're going to be doing in 1 minute's time. And you've got 1 minute to get ready, the kit that you're going to use to do a front of neck access, and a process of mental rehearsal. And you'll see an athlete, if you go to the 100 metres or something like that, you'll see athletes that are sort of going in their mind, this step, hurdle, whatever it is, something that they've prepared for. That's what you're going to need to do. In a minute's time, you're going to need to be ready to go. You might not actually be needed because, in fact, the tube goes in or everything's fine. That minute's going to buy you an enormous amount of comfort when you go, actually, I'm going to be using this hand, hold here, this scalpel, right, cut through and you can actually see people preparing for a surgical airway, either in a sim or a clinical. You actually see their hands moving as they do the procedural steps of what they're going to do. That person is now ready.
All right, I'm going to have to wind it up there. We're out of time. So just quickly to summarise, we've gone through a whole journey of an airway scenario there, where we've heard that preparation is key. We need briefing, we need role allocation, we need two-way communication during this briefing so we can de-bias each other's thinking. We've seen how quickly communication can lead to high consequence errors in these situations, and we need to acknowledge the human factor involved here and build barriers to those errors that can occur with communication. We've seen how hard it is to team lead when you are task fixated, and that hands-off team leadership and maybe being fluid around who has that team leadership, but ensuring that situational awareness is maintained and fixation error isn't a big player in the problems there. We've talked about the problems with terms like oxygenation, and we've concluded that the use of end-tidal CO2 as evidence of oxygen delivery to the alveoli is key during these situations and should be part of the process from the get-go, not just put on once intubation has occurred to confirm tracheal placement of the tube. Recognising alveolar oxygen delivery, restoration of, during an airway crisis is the time that we need to take to slow down, optimise the patient, and re-explore our airway strategy. Not just a plan, not just a backup plan, but another strategy including who and when a surgical airway is going to be by and when it's going to be performed. We've recognised the barriers to actually performing that surgical airway, and by planning early, standardising equipment, putting it in a heuristic location where people can see the kits is all going to contribute to issues there. And trying to avoid or recognise the pitfalls of colloquial or acronym-based communication, which may be restricted to your local area. We've got Dan, who was the anaesthetic registrar from that video here, and he's promised he'll only communicate in acronyms and initialisms for the next couple of days. So if you want to go and speak to him, he'll give you that word salad. So at this point, I want to thank you all for participating. I particularly want to thank my co-host Gerri and the panel members for being part of this, and for everyone that was part of making the videos. And I want to thank all of you for coming along to the meeting. So thanks very much.